Thank you so much, Dr. Sharma, for that exciting talk. As you heard from Dr. Sharma, the past few years have seen a surge in the number and types of cancer for which immune checkpoint inhibitors are an FDA-approved treatment. Our next speaker today, Dr. Alexander Egermont, is going to tell us about some exciting results from a phase 3 clinical trial evaluating a new use for the immune checkpoint inhibitor Pembrolizumab. Dr. Egermont is Director General of Gustave Roussy Cancer Campus Grand Paris in Villejuif, France, where he is also Professor of Oncological Surgery. He has played a leading role in establishing immune checkpoint inhibitors as a standard of care for melanoma, and we're looking forward to learning about his latest clinical trial in this area. Please join me in welcoming Dr. Egermont to give his presentation, which is titled Pembrolizumab versus Placebo After Complete Resection of High-Risk Stage 3 Melanoma, Efficacy and Safety Results from the EORTC 1325 MG Keynote 054 Double-Blinded Phase 3 Trial. Dr. Egermont.
So, good morning all. It's my privilege to present this EORTC trial addressing the question whether pembrolizumab in the adjuvant setting for high-risk stage 3 melanoma patients, these are patients with regional positive lymph nodes, after surgery is a good indication, and therefore a double-blind randomized controlled trial comparing pembrolizumab versus placebo. Here are my disclosures. So, pembrolizumab is an anti-PD-1 antibody, and it avoids the PD-L1 binding at the tumor site because that binding suppresses CTL activity at the tumor site. So, here you see the T cells that are out there to kill tumor cells. But there's a defense mechanism by tumor cells and by myeloid tumor-infiltrating cells through the expression of PD-L1 ligands that can engage with the PD-1 ligand on the T cells to neutralize their function. And so you can avoid this interaction with anti-PD-1 antibodies, and the most renowned are nivolumab and pembrolizumab in the field of melanoma, and you can actually achieve the same thing with anti-PD-L1 antibodies. So now, all of a sudden, since about 7 years, we have effective drugs in advanced melanoma after very long decades of having nothing. And when you look at the curves for advanced melanoma, you will see a picture that can be translated directly in what you will see emerging in the adjuvant setting. So here you see how patients with advanced melanoma basically do not respond to chemotherapy, and this decline continues, and overall survival at 5 years is around 10%, and at 10 years is around 5%. Then ipilimumab was the first immune checkpoint inhibitor that was approved for melanoma. You see a decline, but what you don't see yet in this figure is that it will reach a plateau at 20% overall survival, which will continue to be out there at 5 and at 10 years. And so it more than doubles overall survival in patients with advanced melanoma. If you have a BRAF mutant melanoma, then a BRAF inhibitor has an immediate effect, but a relatively short-lived effect, and then you see the decline through relapses, and this line continues and will join the chemotherapy line at around 3.5 years. And so this transient effect is due to resistance to BRAF inhibitors alone. You can improve that effect for BRAF mutant melanomas by combining a BRAF and MEK inhibitor with a longer immediate effect. But then you see that decline also coming and installing itself. The interesting thing about what we actually consider as pretty much a miracle drug, anti-PD-1, is that its effect in advanced melanoma kicks in later, slower, but that the curve actually takes time to kick in, but then the curve does not descend as quickly as any other treatment. And so it crosses the line of BRAF-MEK combo at about 1.5 years. And then these immunotherapies, be it with anti-PD-1 alone or anti-PD-1 plus ipilimumab, which is marginally better, shows you that at 3 years out, you have the superior approach for advanced melanoma. And the amazing thing is that you will see the parallels now in the translation of this, what we know in stage 4 disease, to also be true in adjuvant setting. So we had the old era with interferons. We had approval of high-dose interferon in 1996, low-dose interferon in 1998 in Europe, and pegylated interferon in the US in 2009. All this with very, very marginal effects, and therefore never becoming a real standard for adjuvant therapy. But now in the new era with the new drugs, we see that the whole scene has changed completely just within a short time span of 4 years. Ipilimumab was the prior EORTC trial, 18071, that showed that in the adjuvant setting, it created a hazard ratio for relapse-free or recurrence-free survival of 0.75. And based on these data, it was approved by the FDA in the USA in 2015. A year later, we could show that also it has a significant impact on overall survival at a level of 11% absolute survival rate difference at 5 years. Then nivolumab, the anti-PD-1 of BMS, was randomized against their ipilimumab, and in December 2017, so last December, it was approved by the FDA on the outcome of this trial, the Checkmate 238, with this hazard ratio for recurrence-free survival. The Dabrafenib and trametinib, the BRAF-MEK inhibitor combination for BRAF mutant melanoma, was shown to have also a very significant impact on relapse-free survival and is under current approval procedures and could be approved, any day. And so I do not know how to click back because it doesn't react to that. And then I will therefore then now tell you about the Pembrolizumab trial with a hazard ratio of 0.57 against placebo. And so let's look in detail at the trial design, because this is where you can see the uniqueness of this trial and how this trial will generate additional answers to crucial questions in terms of what is the efficacy of adjuvant therapy. So we have a population of 1,019 patients that were randomized with postoperative high-risk resected stage 3 cutaneous melanoma. They either received pembrolizumab at a flat dose, 200 milligrams IV every 3 weeks for a year, or placebo with the same schedule. And now, what happens when there is a recurrence? And this is the uniqueness of this trial. If you are in placebo, so first of all, at relapse, you are being unblinded as a patient. And if you were in the placebo arm, you have the crossover offer for free access to the clinical trial drug, pembrolizumab. So this is the only adjuvant trial ever conducted with a crossover to be able to ask and answer the second question. Because all these patients now have access to pembrolizumab at time of relapse. And so the question is, will they do as well as if they had obtained pembrolizumab in the first place immediately after surgery? And that second part of this trial answer in terms of overall survival outcome will of course take longer, because we will report on recurrence-free survival today. But in 2 years, in 2.5 years, we will have the answer to a crucial question, and that is, when giving adjuvant therapy to all, do you obtain a bigger benefit than when you would just follow them and treat them with this active drug at the time of relapse? And I have to thank Eric Rubin, who was the head of R&D of Merck, to stick with me with this proposal and to get it through and accepted by the company Merck. And I think it's really the right thing to do. So stratifications in this trial is subdivision of stage 3 in 3A, B, and C, and by region, North America versus Europe versus Australia, New Zealand, and other countries. The primary endpoint is double. There is a co-primary endpoint, one for the intention to treat overall population, relapse-free survival, and one recurrence-free survival in patient for the PD-L1 positive tumor patient population. The secondary endpoints, I will only report on safety today, but the other ones are distant metastasis-free survival and overall survival and health-related quality of life. So it needs to move forward, but it doesn't. Yes, thank you. So the co-primary endpoint is the PD-L1 positive patient population. And for this, tumor material, so lymph nodes, were stained with a PD-L1 staining procedure. And the ones who had a score of 0 or less than 1% detection of PD-L1 expression in the tumor were classified as being PD-L1 negative. The ones who had more than 1% expression, whether it was 1 to 10, 10 to 33, 33 to 67, or 67 to 100, were classified as 2, 3, 4, and 5, and were therefore then called PD-L1 positive patient population. Why did we do this exercise? Because in the advanced disease situation, the Keynote 001 population, it was established that the PD-L1 positive patients did better than the PD-L1 negative patients. And thus, we thought it might be a prognostic factor important enough to make it a co-primary endpoint for the PD-L1 positive patient population. The key eligibility criteria are classical in terms of age and surgery to be done. The stage 3A population has the lowest risk of relapse, but we further removed from that population patients who had only one positive sentinel node and then a metastasis smaller than 1 millimeter, because that's these two curves, and the relapse rates are too low. It would dilute the population of the clinical trial too much, and we would have to wait far too long to get an answer in terms of events. So we only let them in if they had a metastasis bigger than 1 millimeter in diameter. And then stage 3B and 3C, of course, were the regular patient populations in the trial. No prior systemic therapy, no autoimmune disease, randomization within 13 weeks after surgery. So what are we going to report about here? About the primary endpoint, recurrence-free survival. That is time to local regional recurrence or distant recurrence or death, whatever comes first. The stat plan requested 409 events to have enough power for this type of hazard ratio, 0.70. But we decided to do an interim analysis. And what made us do an interim analysis was the report of nivolumab being more efficacious than ipilimumab. And so we knew, because we had conducted that ipilimumab trial, that this was far too conservative a hazard ratio, and we should analyze our trial data earlier. And we got permission by the IDMC to do this interim analysis on 351 events. I will not report on the overall survival, that will be in 2.5, 3 years, but I will say something about distant metastasis-free endpoint and of course about toxicity. So this is the current analysis about the primary, co-primary endpoints, and so let's look at it. First of all, was it balanced? Well, of course, when you randomize 1,020 patients, you're going to have a balanced table in terms of whatever is in blue is pembrolizumab, whatever is in red is placebo, and the percentages for the important prognostic factors are basically identical, and so the study is very well balanced. And this is also true for the other additional patient characteristics, PD-L1 status. Just to point out that PD-L1 positive patients was 84% of the patient population. It was only 11% that was PD-L1 negative. We'll get back to that. And we also determined BRAF mutational status. So here is the primary endpoint graph. What it shows is recurrence-free survival in the intention to treat population. And the top curve is pembrolizumab, and the bottom curve is placebo. The hazard ratio is 0.57. That means there's a 43% risk reduction of relapse or death. In absolute terms, what does that mean? It means that at 12 months, the difference is 14.4%, and at 18 months, the absolute difference is 18.2%. Very substantial differences, and importantly, the curves are diverging. So this indicates that it will actually get better and more significant over time. Then the co-primary endpoint is the PD-L1 positive patient population. You see similar patterns, Yes. You see similar results compared to the overall patient population, and you see here roughly a 20% difference at 18 months. The PD-L1 negative patient population has a remarkably favorable hazard ratio, but there's only few patients in this in these curves, because it was only 11% of the total patient population. And this is a stratified analysis, whereas in the unstratified analysis, the hazard ratio was 0.60. What's my conclusion, or our conclusion, is that it doesn't matter whether you are PD-L1 positive or negative. PD-L1 negative is not better than being PD-L1 positive. So I need the next slide. It doesn't move forward. Yes. Now the other subgroups, predefined, and because the trial was stratified for bulkiness of disease as stage 3 patients. So these are the most favorable patients, stage 3A population. And you see that the hazard ratio is very favorable, 0.32. And with these type of differences of 14% at 18 months. Then the more advanced stage 3 populations, stage 3B and stage 3C, you see the patients are doing worse, but the impact of pembrolizumab is basically the same in these two patient populations, with hazard ratios of 0.56, 0.58, and therefore, again, absolute differences of around 20% at the 18 months follow-up point. Did it matter whether you were BRAF mutant or whether you were BRAF wild type? Basically, no. You can see that with these hazard ratios, 0.57 for the BRAF mutant patients versus 0.64 for the wild type, this is roughly what we also see in the advanced melanoma situation, where BRAF mutant patients seem to be just a little bit better on doing better on pembrolizumab. And so in the forest plot, it's clear that all predefined subgroups have a similar type of benefit from the adjuvant pembrolizumab treatment. Now another important point, and that is, what is the cumulative incidence of distant metastasis as first relapse-free event? Remember, they all had undergone a complete lymph node dissection to enter into the trial. And you can see that the relapse rate at 18 months is 16.7% for the pembrolizumab patients, and it's almost 30% for the placebo patients. So that's almost double, and therefore it's clear that the hazard ratio for DMFS is going to be expected, not inferior and potentially better than the hazard ratio for relapse-free survival as the primary endpoint. And so that's extremely encouraging. And we know from the analysis of all the adjuvant trials that once you have RFS and DMFS line up like this, normally that also translates into an overall survival benefit. Patient disposition and treatment. So just look at the yellow highlighted items. Disease recurrence drives off 21% of patients with pembro, but almost double, 35–36% with placebo. Adverse events, of course, there is an immune-related adverse events with pembrolizumab that can drive off patients in roughly 13–14% compared to 2.2 in the placebo arm. In terms of general adverse events, therefore, we do see that in grade 3, 4, and 5, we have a 14.7% rate in the pembrolizumab arm compared to 3.4 with the placebo arm. So instead of showing you tables, because to look at tables with 15,000 people is usually not a very good idea. Everybody gets lost on the screens. I'm just going to take you through this slide to show how low, actually, the immune-related adverse events that are severe are with the anti-PD-1 pembrolizumab treatment. So I'm going to take you from the left upper corner to the left bottom, and then to the right upper corner to the right bottom, so stay with me. 0.2% is one patient. So let's look at, first of all, skin immune-related adverse events. It's there in blue. And there's only 3 patients out of 514 patients receiving pembrolizumab who had a grade 3-4 skin event. Then you see there's 1 patient with myositis, and this is an extraordinary patient because it has not been observed in the thousands of patients receiving pembrolizumab in the advanced setting. It's a myositis case that is related to pembrolizumab that the patient could not get rid of and eventually also touched on the intercostal muscles and contributed to his death. So we have 1 grade event. Grade 5 event. There was 1 patient with a grade 3 pancreatitis. There are 10 patients only with a grade 3-4 colitis, which is 1/3 of what you would expect to see with ipilimumab. There are 4 patients only with a pneumonitis. So I take you here. 1 patient with a myocarditis, 7 patients with hepatitis, and 2 patients with nephritis. And then you see a lot of thyroid immune-related events through a short-lived hyperthyroiditis and then go into a hypothyroidism, which is easily treated. And this is actually relatively specific for anti-PD-1. It's 1 in 5 patients, it's 20%. But the serious ones, like hypophysitis, only 3 patients. Diabetes, 5 patients. Adrenal isolated event, only 1 patient. Meaning that in total, there were only 39 patients with grade 3-4 immune-related events in the 514 treated patients. So for those who look at webcast and who want to relook at this presentation, I have included these tables that I'm going to skip now because all was on the slide that I took you through. So I would like to make the following summary and conclusions. Our trial, EORTC 1325 Keynote 54, did meet its primary endpoint of a significant improvement in relapse recurrence-free survival with dosing pembrolizumab at a flat dose every 3 weeks for 1 year compared to placebo. In the ITT overall population, a hazard ratio of 0.57, of course highly significant, and an absolute difference at 18 months of 18.2%. In the PD-L1 plus population, similar type of hazard ratio and almost 20% absolute difference at 18 months. We see consistent results across all pre-specified subgroups, and anti-PD-1 has an extremely favorable safety profile. Severe immune-related adverse events are very rare and generally consistent with what we already know and have seen in advanced melanoma. There were, however, many grade 1-2 thyroid events, 20%. And this probably is due to the fact of the duration of exposure, but this is very easily managed. And actually, there were only in 9 patients endocrinopathies that were severe. In 9 out of 514 patients. So it really has a fantastic therapeutic index, and therefore it qualifies as a good option for adjuvant therapy. So most immune-related adverse events were easily managed and resolved, and the data remains blinded for DMFS, but you have seen our early data that it looks very, very promising. And overall survival, which will be reported at a later stage at future meetings. So, it just was published online in the New England Journal of Medicine, so you can go into depth into all the details of this study as much as you want to. And so I, first of all, would like to thank all the investigators in this trial across all continents. I want to thank the EORTC headquarters team, and in particular the statistician Stefan Sochou, with whom I have now been working for 20 years, and we have done 8 adjuvant phase 3 trials together, and it's been a delight to work with him. I want to thank Merck, and in particular Eric Rubin, who supported me right from the start with the design of this trial. It's the only trial with a crossover, and so it will give an answer to the second question, which is crucial and should be answered. And Najet Ibrahim in particular. And then, of course, our gratitude to the patients, their families, friends, and thanking Merck for sponsoring the study. I think it's also a nice platform to declare my love and admiration for March 40, and I thank you all for your attention.
Thank you, Dr. Egermont, for that interesting presentation. I would now like to introduce Dr. Anthony Ribas, Professor of Medicine, Surgery, and Molecular and Medical Pharmacology at the University of California, Los Angeles, and Director of the Tumor Immunology Program at the Johnson Comprehensive Cancer Center. Dr. Ribas, who's also Director of the Parker Institute for Cancer Immunotherapy Center at UCLA, is an expert in developing innovative ways to treat melanoma by harnessing the immune system, in particular using immune checkpoint inhibitors. This morning, he will discuss the importance of the results that you just heard about from Dr. Egermont. Please join me in welcoming Dr. Tony Ribas.
Thank you very much, Dr. Mardis, and thanks to the organizers for the honor to discuss this excellent presentation by Dr. Egermont and his colleagues from the EORTC on the adjuvant treatment with pembrolizumab in patients with high-risk melanoma. We've got 4 randomized trials reported in the last 2 or 3 years showing improvement in relapse-free survival in patients with high-risk melanoma. The first one, also a presentation by Dr. Egermont and his colleagues at the EORTC, comparing the anti-CTLA-4 antibody ipilimumab with placebo. Shortly after, just 6 months ago, a clinical trial that showed that nivolumab, an anti-PD-1 antibody, is superior to ipilimumab, the CTLA-4 blocking antibody. This study being in a slightly worse patient population of stage 3B and C and stage 4, as opposed to this one, which is all stage 3. At the same time, there was the presentation of the BRAF inhibitor, dabrafenib, and the MEK inhibitor, trametinib, being superior in relapse-free survival for placebo in patients with a BRAF mutant melanoma with a big separation during the first year and maintenance of the separation throughout the study. And now we have this 4th clinical trial of pembrolizumab versus placebo. These 3 clinical trials enrolled patients from the same stage, stage 3, B, and C, have similar numbers of patients, and the control is placebo, while this study is on a slightly more advanced stage, and the control arm is ipilimumab, which was the experimental arm in this study. So from these studies, we can get preliminary results of in relapse-free survival, and we can say that nivolumab, an anti-PD-1, is better than ipilimumab, an anti-CTLA-4, and is better than placebo. Then pembrolizumab is better than placebo, and the BRAF inhibitor dabrafenib plus the MEK inhibitor trametinib is better than placebo. So we have 4 clear winners in these 4 studies: nivolumab, pembrolizumab, and the combination of dabrafenib, trametinib, improving relapse-free survival in patients with metastatic melanoma. But obviously, that opens a series of new questions. And I'm going to try to address 3 of them. The first one, does this adjuvant therapy that improves attempt to relapse, does it also improve survival? We have 2 PD-1 blocking antibodies that improve, so it's one better than the other. And the third one, in patients with BRAF mutated melanoma, should we use anti-PD-1 or should we use a BRAF-MEK combo for the adjuvant treatment of stage 3 melanoma? Only 2 of the studies are mature enough to report on overall survival data. The most mature study is this one of ipilimumab versus placebo, which has been reported and published in the New England last year with the mature events for overall survival. If you're not used to looking at Kaplan-Meier curves, this drop here at the end is something where there's very few patients. So this study, the curves are relevant up to around here. The fact that they cross here doesn't mean much because there's very few events. These are the study, the brafenib trametinib versus placebo had an interim reporting of overall survival and showing that along with the relapse-free survival, this improvement in overall survival in this study, final results will need to be followed. But the two studies with anti-PD-1 blocking antibodies are too early to report. They're both reported as interim analysis of relapse-free survival, the primary endpoint, and overall survival events. There's not enough of them. So the next question is, one of these PD-1 blocking antibodies better than the other. And here are the two studies, the nivolumab adjuvant study and the pembrolizumab adjuvant study. They're difficult to compare because they have different comparator arms. This study had an active comparator arm, ipilimumab, which is better than placebo and it improves overall survival over placebo. And this study compares with placebo. These are studies that are first interim analysis, so you can see all these tick marks after 12 months, with the majority of patients not having gone far enough to be able to know where the tail of the curves are. They also enrolled patients with different stages. This is a stage 3, A, B, and C, and this is a stage 3B and C, and patients with metastatic melanoma that had been surgically resected. But if we look at the experimental arm of these studies, they're more or less overlapping, and would take that this is a little bit better staging than this one. We can conclude that there's not that much difference, and for everything else we know about these two agents in melanoma and in other diseases, I would say that it's like Coke and Pepsi. There are two similar flavors from two different companies with two different packages. The last question is a little bit harder to address, which is, in patients with BRAF-mutated melanoma, should we use an anti-PD-1 blocking antibody, or should we use the combination of a BRAF and a MEK inhibitor? These are the two relevant studies. They have similar staging. They have the same comparator arm, but they're different in one major thing, which is these patients are selected for having the BRAF mutation, and they get a BRAF and a MEK inhibitor, which are highly active agents, and we can see this very big separation of the curves over the first year, and then maintenance of the separation throughout. Here we can see this effect that Dr. Eggermont cited on the immunotherapies, which is patients are not selected for a particular marker for response, and so the curves are closer at the beginning and then they separate afterwards. Also, these clinical trials have different follow-up. You can see that 1 year, the 12 months is here for this study, and the 12 months is here for this study. So we need to stretch this one out to be able to really see and try to compare them. Still, there's the difference of BRAF mutated patients here and BRAF mutated wild type here. So if we look at this, we can see that this is a study where the tick marks of censored patients, it starts even before 12 months. So it's a very early readout of relapse-free survival. So actually, currently we can only compare them on the first year. And we compare them on the first year. Obviously, in patients with BRAF-mutated melanoma, there's a bigger benefit over the first year. But we all are interested to see where this curve settle with the tail of the curve. So once we have follow-up of this study, we could better compare it with this one and try to think with longer-term outcomes, is one better than the other, or do they continue to look similarly? BRAF inhibitors can only be given to patients with a BRAF mutant melanoma. And in the study of the EORTC Keynote 054 study, they look for patients with BRAF mutation or BRAF wild-type melanoma given pembrolizumab. And we can see remarkably that the 1 year and the 18 months events are exactly at the same level in patients with BRAF mutated melanoma and patients with BRAF melanoma, suggesting that a PD-1 blocking antibody has similar activity in patients with the mutated, BRAF mutated or BRAF wild-type melanoma. So if we cannot compare them with the clinical data that we have so far, we can then try to think the different mechanisms of action. And here I try to depict a patient who has a primary melanoma and 2 sites of metastases. And let's assume that you see them here because we know they're there, but the scans do not see them. So these are subclinical metastases that may grow over time. So if we take out the primary melanoma and the lymph nodes, and then we render the patient disease-free from the primary site and the lymph node metastases, but we have these subclinical metastases. Then we can think, what are these therapies doing to try to prevent these metastases from growing? And this is a patient with a BRAF mutant melanoma, and the tumor is growing. The tumor is driven by this oncogene, BRAF, that's a kinase that now it's turned on all the time, and it's giving a proliferative signal to the cancer cell. So it makes a lot of sense that if we block the signal with a BRAF and a MEK inhibitor, we'll have a major effect. And if we start with very few metastatic sites, very few cells that are left, the likelihood of developing resistance is probably going to be less than if we start with big, bulky tumors where the tumor heterogeneity may allow the development of resistance. A PD-1 blocking antibody requires that there was a T cell that recognized the tumor antigen through the T cell receptor. It triggered the expression of PD-1 receptor and the production of interferon gamma, which signals through the signal transduction pathway that leads to the expression of PD-L1 that's reactive to the T cell infiltration that turns off the T cell from PD-1. And only when we have this physical interaction between the T cell and the tumor, and we have PD-1 and PD-L1 interacting, then we'll displace it by giving a PD-1 blocking antibody. Which then makes us think that if these metastases that are maybe not that immunogenic and not growing may not be attracting T cells, and maybe these T cells then don't need to be blocked for PD-1. So my prediction or thought about this may be that at some early time point, these therapies should not be working because these ones require cell proliferations and these ones require a T cell infiltration into the tumor. So we can take the earliest stage, the stage 3A, and try to compare the two studies. And I stretch them out so the time is correct. So this is the dabrafenib trametinib, the BRAF plus MEK inhibitor versus placebo. We can see that in this group of patients, on the first year, there's only 2 patients who relapse. Once the treatment is given for a year and continued, we can see that the separation of the curves continues to be there. With pembrolizumab, there's a little bit more of a drop early, but also an outstanding relapse-free survival at 1 year and continues to follow up, suggesting that my bias that these therapies may be more active in more advanced stages and less advanced is probably not true. There's another way we can look at this data, which is the toxicities. And in short-term toxicities, here we have for nivolumab, I added the nivolumab data from the nivolumab versus ipilimumab or pembrolizumab. They're very consistent with the rate of grade 3 to 4 toxicities, which is higher with dabrafenib and trametinib, the BRAF and MEK inhibitor. But this is a therapy that's a pill therapy that once stopped, these toxicities go away. The toxicities leading to discontinuation is also higher with these combinations. It's lower with nivolumab, not reported with pembrolizumab. It should be the same. But there's one set of toxicities that need to be discussed carefully with patients, which are the toxicities that happen during therapy or after therapy and may last for a long, long time. And these are the endocrine toxicities that can be seen with nivolumab and pembrolizumab with the PD-1 blocking antibodies. As you saw, thyroid dysfunctions can be up to 20%, type 1 diabetes in 2 to 3% of the patients, and adrenal insufficiency in 1 to 2% of the patients, leading to the patients being in lifelong hormone supportive therapy, which is something that obviously needs to be discussed when trying to prevent relapses from melanoma. There's 3 clinical trials that haven't been read that are relevant in the next years. ECOG 1609, which is high-dose ipilimumab versus high-dose interferon versus 2 doses of ipilimumab, waiting for overall survival events. SWOG S1404, which is pembrolizumab versus high-dose interferon or ipilimumab. We'll have first interim analysis hopefully this fall. And then this study Checkmate 915, which is an accruing study of nivolumab and placebo versus nivolumab combined with ipilimumab. So with this, I wanted to convey that we have great advances in the field. We have several therapies that improve relapse-free survival, including the anti-PD-1 nivolumab or pembrolizumab, and the BRAF and MEK inhibitors, dabrafenib and trametinib. We need longer follow-up of these studies to assess benefits in overall survival in different patient subgroups. The decision of which therapy to be given should be made by discussion between the physicians and the patients, and trying to convey this data as well as possible after the health authorities have approved these agents. And once they've done that, I would assume that the older adjuvant therapies, high-dose interferon, regulated interferon, or high-dose ipilimumab, are no longer warranted. Thank you very much.